Okay, we have 57 participants right now. I'll give it a few more seconds before I get it started. Alrighty, let's get started, guys. Happy Friday and good afternoon to everyone. On behalf of the American Heart Association, St. Louis staff, and volunteers, I want to thank you all for joining us for our third in the series of virtual community conversations on COVID-19 and cardiovascular diseases. I'm Blair Ledet with Fox 2 News, and I am honored to serve as your moderator today. So first and foremost, I hope you guys and your families are safe and healthy. Quick housekeeping note to all of our participants joining in. Hello, how are you guys? All participants be in listening mode only, so no video. You would click the chat at the bottom of your screen to activate that chat box, and we will be saving some time for you guys to ask questions at the end, so feel free to put those questions in the chat box. So as with previous conversations, we aim to keep you all informed related to coronavirus and the impact on our community. We'll also be sharing the support and resources available through the American Heart Association. We aim to be a trusted voice in this noisy and chaotic environment of this coronavirus pandemic. Your continued support has allowed us to pivot and respond to this pandemic. You've enabled the American Heart Association to continue to serve its mission, and that is to be a relentless force for a world of longer, healthier lives, and it's more important now than ever. So I would like to take a moment. We're going to start our introductions right now to acknowledge and offer thanks for the support from BJC Healthcare for today's community conversation. I'm pleased to have an expert panel of health leaders joining us today as we explore COVID-19 and its impact on patients living with or at risk of cardiovascular disease. So here we go. First, I would like to introduce Dr. Gregory Ewald. Dr. Ewald is an interim chief of cardiology of Barnes Jewish Hospital and the medical director of the heart transplant program at the Washington University and BJC Transplant Center. He completed medical school at Northwestern University, a residency at BJC, and a cardiology fellowship at Washington University School of Medicine. Dr. Ewald is also the cardiac medical director for Mid-America Transplant, the region's organ procurement organization. His research focuses on multi-center clinical trials of medicine and device therapies for people with heart failure and in need of heart transplantation. Right now, he's working to develop novel imaging modalities to diagnose left ventricular assist device. He is also studying the ability to predict recovery of donor heart function after brain death. Whew, impressive. Whew, big words. Very smart people, very smart people. So next, Dr. Bria Giacomino. Dr. Giacomino is an assistant professor of cardiology of BJC Hospital and Washington University. She completed medical school at Midwestern University, Glendale, and internal medicine residency and cardiology fellowship at the University of Iowa Hospital and Clinics, and a critical care fellowship at Baylor School of Medicine in Texas, that's my hometown, Heart Institute. Well, her research interests include cardiac arrest, resuscitation, and survival, critical care outcomes, and mechanical support with IABP, Impella, and ECMO. She's working on projects involving vasopressor outcomes and various methods for mechanical support devices. She's also working on a lot of clinical trials and genetic studies surrounding SARS-CoV-2. And our third panelist is Dr. Kory Lavine. Dr. Levine is the principal investigator of a basic and a translation science laboratory that's focused on understanding the importance of therapeutic implications of immune cell diversity in cardiovascular diseases. His group has discovered that the mouse and human heart contain distinct macrophage populations with divergent origins, repopulation dynamics, and functions. Current projects within his group are aimed at developing new strategies to reduce inflammation and enhance the capacity of a failing heart. His group is also exploring heterogeneity amongst other cell types for the pediatric and adult human heart using cell technologies. And Dr. Levine is also practicing board certified cardiologist with expertise in advanced heart failure and cardiac transplantation. So very well qualified to answer our questions today, and we're going to get straight to it. So thank you all so much for joining us today and taking this time out. I'd like to kick off our conversation today with Dr. Ewald. As a reminder to our audience, the format today is conversation. It's rare we have this chance to hear directly from our experts in the field. So thank you, Dr. Ewald, and thank you all for all you do for our patients and our families. So here's our first question for Dr. Ewald. We're just a few days into some of the national and statewide restrictions being lifted. How do you think we're doing as a region? And what is the most important thing St. Louisans should know about the COVID-19 pandemic right now?
Thanks, Blair. Thanks to you and Fox and the AHA for asking us to participate today. It's a great group of faculty from our cardiology faculty. I think we've done a fantastic job in the past 6 to 8 weeks as we've really adjusted to the arrival of COVID-19 in the community, and what a lot of the modeling that's being done by members of the School of Public Health here suggests that the social distancing and some of the guidelines that were put forth very early have had a significant impact on what could have been a much worse infection rate, hospitalization rate, ICU utilization at our hospitals across the region. So I think that we've done a fantastic job. There was a lot of preparedness planning that went on at the hospital, the university level, and others, and it's had an impact. I guess as you point out, we're now relaxing those restrictions, and I think it's really imperative that we continue to monitor the situation very closely, because a reduction in social distancing could obviously cause us to see a number of cases or an additional spike in cases. So it's going to be very important for the public health perspective to really keep an eye on how things are going as we move forward over the next 4 weeks or so.
Okay, and Dr. Ewald, it's been reported that those with pre-existing conditions and immune-compromised individuals might be at higher risk for poor outcomes with COVID-19 and experience more complications. Is this still true? And what specifically should heart disease and stroke patients and survivors know about COVID-19?
Yeah, so absolutely. We know both from data really across the spectrum, not only in the St. Louis area, but other places, that certainly it's the elderly population that's the most vulnerable. It's those individuals that already have respiratory compromise, underlying lung disease, underlying heart disease, that once they develop a COVID-19 infection, can have additional strain or additional impact on their underlying organ system, such that they really cannot recover sufficiently from the viral infection. So clearly they're at our highest risk. Unfortunately, we've seen that in some of the extended living situations, extended care facilities, and others where close quarters, people with, are at the high risk groups. It's been a very difficult situation for some of those places.
Okay, and so as we think about re-entering public places right now, there's still significant fear about being exposed to this virus. How safe is it to enter our hospitals right now, and how has patient care changed with the COVID-19 pandemic happening?
Yeah, that's a great question, and care has changed a lot. Very early on in the arrival of the pandemic here, we moved to suspend, elective procedures. We moved to perform a lot of visits with our existing patients, even some new patients, via telemedicine. So, everybody has quickly adopted telemedicine practices, which I think are sufficient for some, but not all. And so, as we've been able to flatten the curve and improve the infection risk in the region, and as some of the stay-at-home orders have been lifted, we at the medical center are now in a planning phase to sort of bring back patient care that occurs in the outpatient offices, in the hospital. Procedures that have been deferred are now being planned again. And I think, you know, what we're doing is doing it in a way where we're bringing it up in a measured fashion, so that it doesn't, we don't, you know, overwhelm the system, don't see adverse impacts of that. But I would say that I think it's very safe to enter the hospital. So the other thing that's happened during the course of this is that we've put into place screening practices. Unfortunately, a lot of visitors to the hospital have been limited, but it does decrease exposure risk. So we've really put a lot of processes into place that actually make it very safe to come and, you know, get health care either in the outpatient office or in the hospital. And so what I would urge, I think what we've also seen, if you look at data from the American Heart Association and the American College of Cardiology, that the number of heart attacks that come to our emergency department, the number of, you know, patients that would typically present have gone down significantly. So I'd urge patients who do have an existing health problem or acute exacerbation of that problem to really seek care. Don't be fearful of coming to the hospital to get care, because that may be a higher risk to you than you know, not coming at all.
Dr. Ewald, you talked about how the screening processes have changed in the hospitals. Do you think this is a short-term deal, or will these changes kind of be long-term and stick with us in the future? What does the future of cardiac care look like?
Yeah, I don't think we know yet for sure what that looks like. I mean, obviously it depends on how quickly the virus appears to you know, go away or become a much lower impact problem. I do think the fact that we've been able to institute telemedicine services, I think that what the future of outpatient services looks like is some combination of in-office practice and maybe checking on our stable outpatients by telemedicine. I think that for now, for the foreseeable future, could be several months, you know, maybe even into next year, that a lot of the screening processes, when you come to a hospital, you'll be screened, your temperature will be taken. There may be limitations on the number of visitors you can bring to the office or the hospital. So I think all of those things will stay in place for a fairly significant time until we can really have a handle on what the epidemiology of the virus looks like, and hopefully until we have be able to utilize a vaccine that will impact the risk of contracting COVID-19.
Okay, so I have one more question for you, Dr. Ewald, and this has been really a hot topic for the past 2 weeks in the news. There was a new article published this week in the American Heart Association's journal, and it was talking about how COVID-19 pandemic has unmasked long-standing racial and ethnic health-related disparities. Can you expand on the virus's disproportionate impact on people of color in some communities?
Yeah, that's a fantastic question. And I think, you know, we've known for a long time that there are disparities in healthcare, both providing the care and what we see in our communities. And a pandemic like this really, again, then puts a lot of stressors on the social environment, the healthcare environment, and really brings that out even more substantially and makes it more visible to us. I think that we know that some of the communities in the African American community have a higher incidence of hypertension, maybe diabetes, some of the underlying comorbidities that put them at increased risk, number one. I think that some of the ability to socially distance and really get access to high quality outpatient healthcare gets strained in a situation like this. So I think it's really a multifactorial issue, both the physiology of the virus and how it impacts the body, but then also, as you point out, a number of the other factors that combine to cause this to be an issue for that community. There have been, and I think that's why it's really important that we don't just focus on how we vaccinate for the virus in the future, but it really is going to be a very important issue for the public health community. And, our Institute for Public Health here is very interested in looking at how the impact has been and how we can maybe lessen that impact in the future for those populations.
Okay, thank you so much, Dr. Ewald. We're going to turn next now to Dr. Bria Giacomino. Thank you for being here, Dr. Giacomino. I have the first question for you here. You're working with some of your hospital's most critically ill, so you must be as alarmed as me in relation to this next question. We're seeing reports and hearing stories from the front lines that fewer heart attack and strokes are being reported in our emergency rooms, as Dr. Ewald just mentioned. Are you seeing this at BJC, and why are these numbers down? If you could kind of piggyback off that.
Yeah, great. Thank you so much, Blair, and thank you to Fox News as Dr. Ewald and the AHA. Well, a decrease in our numbers as well, and this is pretty much across the board when I talk to colleagues nationwide. Ultimately, heart attacks and strokes are not stopping. We know that they will continue to occur. And treatment really is the biggest determining factor to the outcome of these events. We have seen this happen before. If you look back to the 2008 recession, the post-recession, we call collateral damage, showed a significant increase in cancer deaths and then cardiovascular deaths as well. One study that came out in 2019 looked at various counties, and the counties that were hit the hardest had the highest increase rates of cardiovascular death from 2010 to 2015. So this is something that's going to continue to happen. Now, why this happens could be a combination of various things: fear of catching the virus, fear of medical bills that kind of leads into the recession mentality. We know that 1%, one study, a rise in unemployment of 1% equated to an additional 0.37 per 100 patient deaths from cancer. So that also plays into it. But ultimately, heart attacks and strokes are not elective things. And if you encourage anybody who's experiencing any symptoms that would be consistent with a heart attack or stroke to please call 911 and don't delay your treatment, because as Dr. Ewald alluded to, these are major things. These are not elective. We need to be acting upon them immediately.
Okay, thank you for that. And I would imagine a lot has changed, as you all have mentioned in the last 2 months, with the way you all approach caring for your patients. How's the medical team had to adapt in response to COVID-19? We know that some of the patients would arrive by ambulance and go straight into the cath lab and open up an artery. In this environment, are there new processes and procedures?
Yeah, so for the most part, our process and procedure is about the same. We do have one extra step where we evaluate the stability of the patient, kind of take an overall look at what exactly their clinical status is. Currently, the AHA has recommended that what we call fibrinolytics, which are a clot-busting medication that had been used in the past and still are used if you aren't able to go to a cath lab within a good amount of time. Revisit that, because some of the data coming out of China and Wuhan, that the increased time to get a patient in and get the procedure done can lead to worsening outcomes. And so they have encouraged us to consider using fibrinolytics and then reevaluate the patient and go for what we call PCI, primary coronary intervention, in the event that is what's needed. So we are taking that extra step, but we also assume that everybody, is at risk of infection, and so we are all protected, wearing all of the PPE that we need to.
Okay, and obviously this is a fluid situation for our health professionals, and you all are learning every day more and more about this. We've heard that coronavirus can cause heart problems like heart attack. Is this true? Have you seen a correlation between this?
So not so much heart attack. There is some data coming out of other areas that suggests that there are an increased risk of what we call myocarditis, meaning that the virus attacks the heart muscle itself. We have not personally seen this. We are seeing some evidence of heart damage, which is very debatable as to what is causing that. As far as the arrhythmias, most of those that we have seen are generally a side effect from some medications. And so we have put into place various systems to monitor those changes in the EKG to make sure that we don't see those come up. And so just monitor that a little bit more closely.
So at one point, like Dr. Ewald mentioned, the hospital systems kind of stopped with elective surgeries. Do any heart or vascular procedures fall into that category?
Yeah, so some of them did, but we have determined that an elective procedure is a procedure that can be delayed for more than 8 weeks without it causing significant compromise to the patient. And so we have, as a group, looked at our procedures. I know our cardiovascular surgeons have also looked at their procedures and kind of determined if the procedure can be delayed, more than 8 weeks or not. For the most part, they have proceeded proceeded kind of as needed. We have pushed some back, we have left some in place, but we've been pretty diligent about going through and making sure that that procedure does need to go in place, and that we do have all of our screening stuff in place as well.
Okay, thank you so much, Dr. Giacomino, and thank you for all of your work in our community. We're going to hear some words now from Dr. Levine. Dr. Levine, thank you so much for being here. You work with patients managing a condition called heart failure. People living with heart disease or heart failure are understandably concerned, especially as we start to open back up in our region. What can you share to alleviate some of those concerns, and what advice would you give those people?
Thank you, Blair, and thank you to Fox and the HA, WashU and Barnesville for the opportunity to participate today. It's a really great forum. So I think that's a really excellent question. I'm sure it's a question that's on many patients' minds. So we know that individuals with heart failure, coronary disease, and other forms of cardiac disease are at higher risk if they do get COVID-19. However, I think it's important to understand that they are at risk from their disease also, independent of the virus. So while there's reason to be concerned, and that's certainly warranted, the most important thing is for them to take care of themselves, to make sure that they're in contact with their physicians and going out and seeking the care and attention that they really need. For our patients at highest risk, our heart transplant population, others, we tell them to do the things that they typically do: wash their hands, wear masks in public, and to keep themselves safe. And I think the individuals with cardiac disease should do the same thing in this situation.
Okay. So we hear a lot of different confusing information about medication. Some patients might be confused or worried that the medicine they are taking might make them more susceptible to becoming infected. Do you have any messages for those patients who are already taking medication, and what could you share about that?
Yeah, great question. Let me speak directly to that issue. So we know that the virus enters cells through a protein called ACE2. And we have a number of patients with heart disease that are on medications that interact with that pathway. They either bind to a different protein called ACE1 or affect that pathway in a different way. And because of that, there was early concern that those patients on those medications would be at a higher risk of developing the disease. We know now that that's not true. And so there's more and more studies that have come out suggesting being on those medications is actually protective and not harmful. And so what we recommend is that patients continue taking the medications that their physicians recommend, and that there's no higher risk of contracting the virus or effect of the virus on the heart for those individuals compared to the general population.
Okay, and so in our coverage, we see this virus affect people in just so many different ways, different ages, different people who are healthy. Is someone with underlying heart conditions going to experience the COVID-19 symptoms differently than those with no underlying conditions.
Yeah, there's a lot of information out there. And I think part of that's because we're continuing to learn as time goes on, as we're developing more experience around the United States as well as in the St. Louis area. What we know is at the population level, when you take large numbers of people and analyze them together, individuals that are older and individuals with heart disease are more likely to have severe manifestations of COVID-19 and be the sickest and be at the highest risk. But we also see that young, healthy patients can also get sick. And so when you're applying those population findings to an individual, it's challenging. It's impossible to point to one person and say that you're at higher risk than another, and that this will be your outcome if you get the virus compared to another person. So we don't really know the answer to that. And because of that, we suggest that people do the kind of common sense measures of taking care of themselves, staying healthy, staying fit, taking care of their medical conditions, and trying to minimize their exposure as much as possible.
Thank you so much, Dr. Levine. Thank you all for all of your valuable information. We're grateful for each of you, and thank you for bringing answers and some clarity to the community in this unprecedented time. And now we're going to move on into the panel discussion portion of our webcast. During this discussion, I encourage all of the viewers to leave questions in the chat box. I see one right here from Jacqueline, but we will have to get to as many questions as we can in the remaining time. We have just around 30 minutes left, so we'll start with some questions that we have already gathered. So Dr. Ewald, we've seen reports that one of the consequences of the virus is availability of organs for life-saving transplants. As a heart transplant specialist, what effects are you seeing, and what does this mean for someone today who might need a heart transplant?
Yeah, that's a fantastic question. I think that it's been impressive to see the community that does transplant here, not just heart transplant, but solid organ transplants across the spectrum, liver, kidney, lung transplants, kind of react to the presence of COVID-19 in the community. We've had weekly calls with the leadership group to look at best practices. We involve specialists from the infectious disease group and infection control to help counsel us on those things. Our organ procurement organization partner, Mid-America Transplant, also participates in those calls. And so the early phase was figuring out, who should we test? Do we test all donors? How do we test people that are being called in from home to get a solid organ transplant? How do we make all those things happen to make sure that the transplant can be done in the safest manner possible? The living related donor kidney transplant program suspended operations for a short period of time to kind of make sure it was going to be safe to resume that in the current climate. And so I think we've put together really nice best practices to make sure that patients can still get transplanted. Obviously, when a transplant occurs, oftentimes a team of surgeons has to fly from here to wherever the donor organ may reside and come back to this community. So there were a lot of concerns about making sure that it was safe to travel and enter these other hospitals. And so a lot of effort's been put into that. And I can say from the heart transplant perspective, we've done 4 or 5 transplants in the last 8 weeks, in this climate in a safe and effective manner, and had good outcomes. So I think that, again, it's those are not elective procedures. And so we've continued to provide that level of care for patients, and working with our partners, at BJC and Mid-America Transplant, I think we've done it in a very effective and safe way.
Okay, thank you so much, Dr. Ewald. The next question is for all of you. The American Heart Association is investing in understanding the coronavirus and cardiovascular diseases and stroke. Are there any emerging studies that have piqued your interest, and how is Washington University approaching this?
Sure, I can field some of that, and then I think Dr. Ewald may also have some comments. So there's emerging cases or emerging data that the virus can infect lots of different organs outside the lung. And we know it likely infects the heart and may be able to infect vasculature, your blood vessels, as well as the brain. And so there's a large research consortium at Washington University that's vested in a lot of different areas. And it's been amazing over the past 6 weeks and to watch everyone galvanize together to understand how this virus infects tissues and to develop new diagnostics and therapeutics to combat this infection. And so our team here is involved in understanding how the virus infects cells. We've identified antibodies that neutralize the virus that have been obtained from patients that have recovered. And we're learning more and more about how the virus infects not just the lungs, but other tissues throughout the body. And so the work done locally at Washington University, as well as throughout the country, has really been done at an amazing pace. We've learned more about this one virus in 12 weeks than we've learned about other viruses in a decade. And I think that progress is really going to pay off in helping patients in the near future.
Thank you, Doctor.
I would add to that, and Dr. Levine's being somewhat modest in his response. He's a great example of a basic science lab that was focused on underlying mechanisms and what happens, inflammation in the heart and how that impacts heart function. And in a few short weeks, transitioned to really look at the effects of COVID-19 and try to understand that. So he's a great example of that, not only in cardiology, but the entire community here and how they've done that. There also been a number of clinical, trials in patients admitted to the hospital. So some of the drugs that you've heard about and plasma therapies that you may have heard about by watching the news and so forth are also being tested here at Washington University. And so I think that the community here has done a fantastic job of not only understanding it at a basic level, but trying to understand it at a care level for patients that are admitted. We've had colleagues within cardiology and myself apply for funding from the American Heart Association, actually put out a request for applications to provide some grant support very quickly in response to this. And so we're we hope to do a study looking at cardiac MRI to see if we can detect scar tissue in the hearts after patients have recovered from a COVID-19 infection, to see if there may be some evidence of long-lasting sequelae of having a viral infection on the heart. So it's been tremendous to sort of watch the community come into play and do it very quickly.
Dr. Giacomino, and all of you can answer this as well. We have these question coming in from our chat box from Chris Comerfield. Sorry if I pronounced your name incorrectly. This person is speaking about patient fear of getting COVID-19 being greater than the fear of delaying treatment of their heart disease or stroke. How should they prioritize these fears? I know that you all mentioned less people coming into the hospitals and probably just being afraid to contract this virus. So how should they prioritize that?
Yeah, I think my biggest kind of statement to this would be that, we do everything that we can to protect patients, protect ourselves. We've got patients who are concerning for COVID in different units. And so, yes, there is a risk, but your risk of getting coronavirus is in the hospital is probably the same risk as going to the grocery store or going to get something from Target. And so I think that my biggest worry is that people delaying their treatment, these will turn into fatal diseases with complications versus, the virus. Yes, you may contract it, but you are in the right place. We can deal with that. But suffering a fatal heart attack is, it requires time-sensitive treatment. And so I really encourage people to not their care if they are having symptoms of that.
Okay.
And I think it's really important to remember still that the vast majority of patients that contract COVID-19 recover. Even some of them don't even require hospitalization, can be monitored and managed at home. And so, I think when you read the paper, watch the news, and see some of this, you don't always hear stories about people that have survived a viral infection and are doing quite well and recovered fine. So I think we get a little bit sometimes a different viewpoint than those kind of out in the community. So again, it's most people recover, and and you should seek care when needed.
Thank you so much, Dr. Ewald. I have a question from Ken Cooper. He says, for those of us who are transplant recipients, should they practice social distance or staying at home longer, or should they do things differently than the next person who is not a recipient?
Kory, you want to take that?
Sure, absolutely. So we've been telling our transplant recipients to do what they normally do, and to keep themselves healthy, which involves washing their hands frequently, wearing a mask when they're in crowds. Now, obviously, wearing a mask when you're outside in general is what's recommended by the CDC, and keeping fit and exercising as you normally would. We tell many of our transplant patients to imagine the situation a little bit like the first few months after transplant. We're spending a little bit more time taking care of yourself.
Okay, thank you so much, Dr. Levine. Dr. Giacomino, we'll ask you if you have any thoughts or concerns for opening cardiac rehab programs, changes that could be made to open those up.
I think, sorry to interrupt you, I think for right now, our department is not reopening as of yet. We do have plans to start reopening, and I think Dr. Ewald can speak a little bit more to that. But currently, I mean, just because of the proximity to each other, I think, eventually we'll open up when we can. Dr. Ewald, I don't know if you want to speak a little bit more to that.
Yeah, no, thanks. Yeah, I totally agree. I mean, we made the decision early on that, again, somewhat close quarters, a high-risk population, using many of the same exercise machines or equipment, we felt like it was prudent to suspend our cardiac rehab program. And just like with everything else, we're starting the planning phase to kind of bring those things back online with very careful attention to safety. And so patients will be screened coming into the facility. We'll probably start to ramp up cardiac rehab in June or at the latest early July in terms of, but at a reduced density. So fewer patients in the facility, processes to clean the equipment and make sure that social distancing is possible. So we strongly believe in cardiac rehabilitation for people with recent heart disease. And so it's an important part of the recovery. And so we want to get it back online as soon as possible.
Okay, and we will go. I don't see any more questions in our chat. You all, if you have questions, feel free to leave them in the chat. I'm going to, before we close, give each one of you an opportunity to just kind of share your final thoughts with our audience. We'll start with Dr. Giacomino. Any final thoughts that you would like to share before we log off?
I think, the reality of reopening for us is a little unnerving, but I think if people just maintain their, wear their mask when they're out in public, wash their hands, as Dr. Levine was alluding to, frequently, avoid touching your face, all of that good stuff. Even if we start to reopen, I think hopefully that will help. And just be conscious of other people and be kind to everybody. Everyone needs a little bit more love today, so.
Definitely. It is, and I could imagine it's very unnerving for you all. What has been the most difficult part of this whole situation for you personally?
I think so. I work mainly in the ICU, and most of my time is in the cardiac ICU, but with this COVID push, I've been in the COVID ICU a vast majority of my time. I think for me, the hardest part is I come from a large Italian family, and so the hardest part for me is having these patients who can't have their families around them. And, sometimes they have to, die by themselves, and that's very hard. And so we do what we can. We've been instituting FaceTime with families, and so we send them a secure that they can video in with their loved one. Even if they are on a ventilator and can't talk to them, they can at least talk to their loved one and let them know that they're there. We have asked families to email our social workers pictures that we print out and put up in patients' room. And so we're really trying to keep that social contact and that family orientation there. But I think that's the hardest part, is just having patients that don't have that support system and trying to be that support system for them.
Thank you so much, Dr. Giacomino. We actually do have another question that came in. I know I was letting you guys have your final thoughts, but I do want everyone's question to get answered if we have a little more time. So the question is, can you share any information or thoughts about the heart respiratory issues, rashes, or fevers happening in children? And is that possibly related to COVID? They're saying it's happening in New York. Have you guys heard of any of this? And is it possibly related to COVID?
Yeah, I can speak to that. My wife's actually a critical care pediatrician, so we were talking about that last night, actually. So there's a number of cases of individuals, children that are developing rashes, swollen joints, other sort of inflammatory conditions, some involving the heart, who happened to have an antibody test that was positive for COVID, meaning that they were exposed to the virus in the past. Children sometimes develop these inflammatory reactions after recovering from viruses previously. One of those types of diseases is called Kawasaki's disease, and there's a number of other syndromes like that. Right now, the link is kind of hypothetical or an idea, and really awaiting proof. But the concept is that a very small number of children may have been exposed to the virus, and then their immune system got revved up so much that they developed manifestations throughout the body that usually manifest as a rash and swollen joints. But we don't know if that's actually a fact right now. I think that's a link and an idea that remains to be proven. In general, children really are not very much affected by this virus. Otherwise, healthy children, if they are infected, many are asymptomatic, and the majority that do have symptoms are really mild. The number of cases that have been seen at Children's Hospital or in the ICU has been very, very small, just a fraction of what we see in the adult population. And so I think in general, kids are fairly protected. They certainly can spread the virus, but they're pretty protected from a disease standpoint. I know people are worried about daycare and schools, and that's an issue that's going to continue to be talked about, I think, throughout the summer as we get closer to fall.
Thank you so much, Dr. Levine. I have another question that's come in. Does COVID affect pacemakers or other implanted devices? Whoever would like to answer that one.
Yeah, really, it shouldn't affect pacemakers. I mean, obviously, if somebody got a really serious, what we've referred to as myocarditis or inflammation of the heart, it could maybe interfere somewhat with the electrical conduction from the pacemaker wires. But again, day-to-day health, if you were infected, it should not affect your pacemaker or your implanted device.
Okay, thank you so much. And we are at about 12:45 right now, so I'll continue to let you guys make your closing remarks or share any thoughts with us. Dr. Levine, we'll go to you. What are your overall thoughts? Any closing remarks you would like to share with our audience?
Yeah, I'd like to echo just a few of the points I think that have been made throughout this discussion. I think the biggest point is, as we open up, there's a lot of fear, and people that are a little bit older or have heart disease are probably the ones that are worried the most. And I want to emphasize that the majority of patients who do contract the virus do just fine. And it's only a fraction that do get sick and need to be hospitalized, and just a fraction of those need to be in the ICU. And so as we open up, I think the most important thing is to focus on taking care of yourself and taking care of the people around you, and not to be afraid, to continue exercising, to continue communicating with your doctors, seeing your doctors, and doing the things that made you healthy previously.
Thank you so much, Dr. Levine. And we will conclude with some last and final thoughts from Dr. Ewald.
Thanks. I think none of us could have anticipated that, we would be in a situation like this. Even those of us in healthcare that have, been through H1N1 influenza and other severe, viral infections couldn't have imagined a situation like this. And it's, I guess from my perspective, both in terms of taking care of my patients, but also kind of being involved in managing some of the response to the pandemic. I think it's been extremely rewarding to see how my colleagues have really stepped up and in a very, very short period of time, again, put patient healthcare and patient safety first, themselves behind that, and really worked, in a fantastic way. And it's required a significant amount of coordination between, the physicians here at Washington University, our partners at Barnes Jewish Hospital and BJC Healthcare System, and really all the healthcare systems in the region have formed this task force that have, worked together to respond to this in the most favorable way. And I think we've seen the impacts of doing that. Again, Dr. Giacomino's being very modest. I mean, she's one of those people that stepped up and volunteered to actually, work in the COVID ICU on a regular basis. And so, to see that happen and to see the response of the healthcare community to this stressor has been very rewarding. And I think, we should applaud everybody and I think try to go on and live life the best we can for the next several weeks but be careful, as Dr. Levine pointed out, that we got to keep our eye on the ball here, because we're not completely past this yet.
One more question for you all. Thank you so much, Dr. Ewald. As we close and look to the future, we all wonder how we will contain the virus. And someone has asked, said that they understand this is a mitigation tactic. How do we get back to containment?
I think from my perspective, again, it'll be, you've heard a lot about being able to test for the virus and get those results back, almost, in a matter of minutes as opposed to hours like it is now. So much like we do with, say, influenza, where people that think they may have influenza they get tested, yes, you have it, and, you stay home and you try to avoid infecting others. I think once the testing gets to that phase, we'll have a much better chance of containing the virus to people that actually have it. And then the next step will be, trying to develop a vaccine that can then prevent potentially some cases of infection in years to come. It's also a plug for, everybody when you're asked to get a flu shot, or hopefully in the future, a coronavirus shot, you say yes and you do that, because I think that's the main way that we will kind of contain and hopefully keep this from being another significant infection in years to come.
Thank you so much, Dr. Ewald. I am going to say we are at about 12:50 right now. For you all, and this is my personal question, how unique has this just whole situation been for you all in all of your years of working in the healthcare systems? How different, how unique is this just in comparison to everything else that you all have seen?
Oh, I don't think there's anything like it. This is probably the most unusual situation, changing situation that many of us have experienced, both working and at home. Families that are two physician couples balancing working and home care and child care and so forth. But it's amazing. I've never seen a hospital have to pivot like it has and shut down its normal operations to make room and capacity and prepare for a large number of patients that fortunately have not come in the St. Louis region. So it's been amazing to watch how nimble our hospital system's been in dealing with this. It's been amazing to watch how our patients have adapted to this and remain in close contact with us. It's been interesting to see how the community has done this, but I think the most kind of surprising thing is seeing how children have handled this and kind of internalized what's occurred. It's a unique experience I don't think we'll ever see again, or hope we don't see again.
Dr. Giacomino?
Yeah, I think just to echo what Dr. Levine was saying, it's, I think from a global standpoint, watching other countries deploy things to Italy and deploy people to New York, and, really how the medical community on, a St. Louis level, on a Missouri level, on a national level, and even a global level has come together to support each other. The sharing of information, I've been on conference calls with people in Italy, with people in New York, with people in Washington. And so, just that awesome collaboration has been really, really incredible. We do this on a routine basis in our daily lives with research and everything, but just to see it happen so fast and just fluidly, and nice. It's been an uplifting part of this, if there is one.
Definitely uplifting, very. Well, Dr. Ewald, do you have anything to share on that?
No, I would totally agree. I mean, just the fact that we're all sitting here, being able to talk to each other on this platform is really, we wouldn't have done this 8 weeks ago.
Right.
So I think, and we're utilizing this not only to, communicate information to each other, but to communicate with our patients. I think there was a question about, doing like cardiac rehab at home even. We're keeping in touch with our cardiac rehab patients to make sure they're safe and doing well. So really, we've changed the delivery of healthcare in a very short period of time. And I think we still have some work to do in figuring out, what the new normal is. But I think it's going to be, there are going to be a few good things that come out of this in terms of how we deliver healthcare. But hopefully it'll be past us and not become a major issue in the next year or two to come.
Thank you so much, Dr. Ewald. And we can all agree here, all of the people in the audience, they're saying thank you all for your dedication. I have so much respect for you all, your courage, again, your dedication, your skill, your intelligence is really so impressive. And I want to just thank you all so much for all that you've done. So we would like to extend our deepest and most heartfelt thanks to those individuals, organizations fighting on the front lines to save lives during this pandemic. We know together we can preserve, protect, and continue to build a healthier community right here in the St. Louis region and across the state. On behalf of the American Heart Association, we look forward to continuing to collaborate with each of you to extend people's lives today and in the future. To that end, before we wrap up, there are always ways that you guys can stay engaged with AHA in achieving their mission of extending lives. You can contact or connect with them with the AHA online. That is www.heart.org/coronavirus. Stay up to date on their social media channels, and most of their platforms will be at AHASTL. And join us next Saturday, May 16th, for the American Heart Association's first ever virtual Heart Walk. So there you go again, Dr. Ewald, just all of these innovative ways to continue with things that have been important for us in the past years. And also be sure to stay tuned for more of these webcasts in our series related to COVID-19 and cardiovascular diseases. Our next conversation is on COVID-19 and the impact on stroke patients. Look for more information on that in a follow-up email. I want to thank you all for joining us today and thank our panelists again for this dynamic conversation. Thank you to our attendees who joined us for your attention and engagement. It's been my pleasure to moderate today. On behalf of the American Heart Association staff and volunteers, thank you to today's sponsor, BJC Healthcare. And this concludes our COVID-19 community conversation. Until next time, I want you guys to stay healthy, stay connected, and when possible, stay home. You guys have a wonderful day. Thank you so much.
Thanks, Blair.
Thank you, Blair.
Thank you.